Well, hello, friends. Welcome to another episode of Intentional Living with Emla podcast. Today, I am honored to have back on the show my wonderful and favorite OBGYN, Dr. Pragna Patel Dadhania.
Hello.
Hi, hi, hi. I am honored. You're so good. We keep wanting you back. We did the estrogen one, and everybody wants to hear more, and they're asking about progesterone, and I'm like, all right, we're going to have her back. So Dr. Dadhania is a board-certified OBGYN, and the reason I have her on this podcast is because she is a Menopause Society certified provider. And you need somebody who has not only done the certification to be the physician and OBGYN, this is her specialty. This is what she spends time in her practice, modern menopause care. She opened her practice to be able to spend time with women, listen to women, evidence-based medicine, put the objective data with the subjective data and be able to take care of patients the way she would take care of herself and the way she would take care of her friends like myself. So thank you again for doing all the things that you do and for explaining things in a way that we can understand.
Well, thank you. That was quite the introduction. Thank you.
It is
and
who you
you're
are.
welcome.
It is who you are because you do that for a lot of people. I had a lady talking to me yesterday and she was like, oh my gosh, where did you find her? She was amazing. And I was like, well, she's my friend. So thank you for coming on. And today, this episode is going to be about all the things progesterone. We have heard about perimenopause and menopause, and estrogen has taken center stage, and everybody is about estrogen. When we talk about hormone replacement therapy, everybody thinks estrogen. Progesterone is left in the background.
It is. But progesterone, it's so important. It's equally important. Yes. And you're right. When we think about perimenopause, we think about estrogen. But honestly, the first symptoms that appear in perimenopause isn't because of estrogen. It's because our progesterone is starting to decline. Oh. Progesterone, we're going to talk about it, but, it's responsible for things like helping us sleep, calming our mood, and it balances that estrogen. So progesterone should be there equal footing with estrogen.
Oh, that's not the case. That is not, I don't see no equal footing. I see progesterone left in the background. So let's back up. Tell me, what is progesterone and what is it helpful for?
Yeah. So progesterone is a hormone. Mm-hmm. It's produced primarily after ovulation. And its main function is to support pregnancy. So that's why we have progesterone. Mm-hmm. So each month we ovulate, our ovary releases an egg, and something called a corpus luteum forms. It forms from that empty egg follicle, and it produces progesterone. And it's doing so in anticipation of a pregnancy. Now, for most women, most cycles, they're not going to end up in a pregnancy. Yeah. And so then we shed this lining that our estrogen helped build up in the form of our period. So that's its main purpose, is to help support pregnancy. But like I said, it does support other things in our body, like sleep, our mood, and it provides a counterbalance to our estrogen.
So progesterone is responsible for also helping us support sleep.
Yes.
So, but now let's talk about what happens to progesterone levels during perimenopause. What happens?
Yes.
Because I feel like last time you mentioned estrogen being the CEO of...
Yes, I did.
I love that analogy. Yes. I haven't stopped talking about it since then.
Well, I have another analogy for you. It's a little bit different.
Let's go.
But I thought it would help kind of women understand what's going on. So I want you to think about estrogen and progesterone like the pedals in your car. So estrogen is the gas pedal or the accelerator. Estrogen is very accelerative. It's building. Yes. It's building the lining of your uterus. It's helping with brain. It's helping with metabolism. It's helping building bone, your skin. And progesterone is like the brake pedal. So it's very calming. It helps with sleep. It calms your mood. It helps stabilize that lining of the uterus. And so in a perfect world, in our 20s, early 30s, the estrogen and progesterone work together. So we have our gas and we have our brake, and they work together so we feel well and whole. Now let's take it to perimenopause. One of the things that happens in perimenopause is that we don't ovulate regularly. It becomes less predictable, less reliable. And progesterone is formed after ovulation. So if we're not ovulating, regularly, we're going to have less progesterone around. So we're going to have less of that brake pedal. We're still making estrogen. Estrogen is still there. We just are losing that progesterone first, and it's not helping balance out that estrogen. So that's why some of the first signs that we see are things like sleep, problems with our periods, maybe we become more moody, maybe we start having mood swings, we have breast tenderness. So really, in the beginnings of perimenopause, I even see some women who come to me and they've been told, oh, I'm estrogen dominant. So it's not so much that you're producing too much estrogen, it's that we're not producing enough progesterone to balance that estrogen.
That is the best explanation I have heard.
I knew you were going to like it.
Oh my gosh, I love that. I love that.
Yeah.
That is the best explanation, like the gas pedals. Oh, I
Yes.
see that. And it now makes sense why you say that some of the first symptoms that we see of perimenopause are symptoms of low progesterone.
Yes. So I see 3 common signs that women can use to kind of gauge if their progesterone is starting to decline.
Tell us.
So one is sleep. So all of a sudden, our sleep is not great. Sometimes it's problems falling asleep, but it's more so the staying asleep. So women commonly in perimenopause will say, I'm getting up at 2 or 3 o'clock in the morning for no apparent reason, and they're up for hours. So progesterone interacts in our brain with GABA, which helps with sleep, which helps with calm, which helps with relaxation. So again, perimenopause, we're not ovulating, we're producing less progesterone, and it's not interacting with the GABA in our brain, so our sleep's going to be more fragmented, it's going to be lighter, and it's going to be one of the first things that we see go. Progesterone, because it's helping with that estrogen with our periods, actually women find, the second sign is that their PMS is worse. So I think women think that as we age and we get into our 40s, our PMS should get better. Right. But in actuality, it gets worse because we lose that progesterone. We're losing that balance to our estrogen, and women can feel anxious or moody or overwhelmed leading up to their period. So that's another sign. Wow. And then lastly, which is also something common we see in perimenopause, is that our periods are getting worse. They're getting heavier, maybe more blood clots, they're coming more frequently, and again, it's progesterone. It's not there to help stabilize the lining that the estrogen is building up. Yeah. So if the progesterone isn't there, estrogen's going to still keep building that lining, and it can get crazy, and you can have heavier periods, you can pass clots, and your periods can come a little bit closer together than what you're used to. So those are kind of like the top 3 early signs of your progesterone maybe being on the lower side.
You've just described the symptoms of all the women coming into the pharmacy and going, I think this perimenopause thing is hitting me. And those are usually the signs that come in there like, oh my goodness. I was literally walking out of the pharmacy this morning to come for and sit down with you for this. And a lady walked in and she goes, do you want to see my grocery list, which I made at 2 a.m. this morning? And she goes, I woke up at 2 a.m. and I just could not go back to sleep. I stayed for a little bit and I was just like, what the heck? I'll pick up my phone and I'll just get some work done. So I made my grocery list. And I'm like, girl, you should not be doing that. First of all, don't pick up your phone when you wake up at 2. But that should be a prime candidate. And she is in perimenopause. Yes. She is a prime candidate for progesterone.
Yes.
So tell me so we see a lot of, right now, the black box warning was lifted off hormones, and we're having a lot of physicians are prescribing the estradiol patches. So there is a back order right now on the patches.
Yes.
But a lot of patients are asking, should I always be on a progesterone if I'm on estrogen? I see some people just on the patches, some people just on progesterone, some people on both. What helps you make that decision?
Yes. So, I'm glad you brought this up because one of the most important reasons when we think about hormone replacement therapy and why progesterone is included is because it is there to protect your uterus from precancer or cancer of the lining of the uterus. Because if we only replaced estrogen, because we think of estrogen as helping with hot flashes and night sweats and brain fog and all the other symptoms, if we only took estrogen, it can stimulate the lining of the uterus and lead to precancer or cancer. So anybody with a uterus, meaning they have not had a hysterectomy for whatever reason, needs a progesterone or a progestin, which is a synthetic progesterone, to protect that process from happening. So if you have a uterus and you want to take estrogen, you need a progesterone because we don't want you getting uterine cancer from taking extra estrogen. However, if you're a woman who's had a hysterectomy, maybe you had fibroids, maybe you had issues with your periods and you had a hysterectomy, well, then you don't have a uterus anymore, so you're not at risk for uterine cancer. And so you can take estrogen alone. However, you can also take progesterone if you're somebody who's finding that, gosh, I'm waking up at 2 or 3 o'clock in the morning consistently, or I'm feeling more anxious than I've ever been. Because progesterone, again, it is a hormone. It was produced by our ovaries. It used to be there in an abundant amount, and it's not. So we don't need it for our uterus. But if you're having symptoms that we attribute to low progesterone and you don't have your uterus, you can certainly take it with your estrogen.
This makes so much sense. If you have not listened to the other episode that Dr. Dadhania and I did on estrogen, please go back and listen to it. We'll put a link to that in the show notes. And it is just nice to talk with somebody who explains the stuff in a way that somebody without a science background can understand. Like, that's one thing I love about you. Like, you explain it and like, okay, I'm just assuming that I'm not talking to a physician right now. I'm not talking to somebody with a doctoral level education. Let me just explain in such a way that everybody sitting in front of me, despite your background, can understand.
Yeah.
I love that about you, and I really appreciate it. That makes it, I use your analogies to explain to patients, and it makes me so happy because they like get it.
Yes.
It's lovely. You snuck in something there, which I want to bring back. You talked about the difference between, you just mentioned progestin.
Yes, I did.
What is the difference between progesterone and progestin?
Yes. So when we talk about progesterone, and a lot of times we use them interchangeably, but progesterone is when we talk about it in a prescription form, we call it either micronized progesterone or natural progesterone or bioidentical progesterone. And these are all, these progesterones are similar to the progesterone that your body was producing. And so that's the type of progesterone that's really going to help support the mood, the calm, the relaxation, the sleep. Now, progestins are synthetic forms of progesterone, and that's what we commonly see in birth control pills, in IUDs, like a hormonal-containing IUD, or sometimes if women have episodes of uncontrolled bleeding, sometimes we give them a progestin to help them stop bleeding. So it's a synthetic form. Typically, it's more potent. Typically, it's going to be better at stabilizing that uterine lining. It works really well for your periods, maybe not as much helping with the sleep and the calm and the relaxation, but it serves its own purpose. So when we talk about hormone replacement therapy, you can do progesterone or you can do a progestin. And again, the decision is going to be based on what symptoms you're having, and what we need to address. Because if you're in perimenopause and you're having terrible periods, the natural progesterone may not be enough to help with your bleeding. But if you're somebody in postmenopause, you're not having periods, but you simply need support with sleep, or we need something to help protect your uterus, usually that natural or the micronized progesterone is usually the place we start because it has those added benefits of sleep and calm, and it helps with your mood.
I love that. So as you could tell listening to this, there are so many things that you take into consideration before determining whether a patient is a good candidate for hormone replacement therapy. And then after that, step 2 is now what type of hormone replacement therapy? Is it going to be estrogen? Is it going to be progesterone? Is it going to be progestin? Is it going to be combination, testosterone, and all that?
Yes.
So this is why I always encourage anybody that comes out to the pharmacy saying, oh, I have these menopause symptoms. It is necessary to listen to your body. It's necessary to sit down with somebody who is qualified to do that. Sit down with a board-certified OBGYN, somebody whose specialty is menopause care, to be able to address your hormones. This podcast is sponsored by Journeys, your path to intentional wellness. Most health problems don't start overnight, and neither does wellness. With Journeys, you can take charge of your health before you have to. Every cell in your body is speaking to you. But when we ignore preventive medicine, we wait until those cells are screaming. Journeys helps you listen to the whispers. There are 3 different journeys to choose from, each designed to meet you where you are in your wellness path. The Core Wellness Journey for $199 offers a foundational look at your overall health, perfect for getting started and measuring 66 biomarkers. The Advanced Heart and Metabolic Health Journey for $339, measures 111 biomarkers, and goes deeper into cardiovascular, metabolic, and thyroid health for a more detailed picture. The comprehensive longevity and hormone journey costs $469 and is the most complete view, including hormone, nutrient markers that support energy, balance, and healthy aging. This measures 120 biomarkers. Each journey includes a personalized recommendation, one-on-one care from your pharmacist, and follow-up support to help you turn results into lasting intentional change. You just won't get data. You'll get guidance, accountability, and a partner in your wellness journey. Intentional living means paying attention, staying curious, and taking steps towards the health you deserve. Start your journeys today. Click the link in the show notes. So we have the Journeys program at the pharmacy, and we do all the measurements. We measure, so you do the lab test, measure your progesterone, DHEA, testosterone, estradiol, all the things, and then you get to sit down with Dr. Dadhania. And when you sit down with her, so we will put her link in the show notes. We'll put a link to the Journeys in the show notes so that you can sit down and have a personal assessment. The essence of this podcast is to give general information, which is just educating people,
Yes.
not diagnosis or anything, but just putting you attuned to listening to your body.
Yes.
And then you take the right steps to meet the right professionals to
Yes.
be able to take care of you. So let's take back. I'm really interested in sleep because sleep, we had Dr. Roy on the podcast,
Yes,
and
that
that
was
was such a hit of a podcast.
Yes, it was a great
And
episode.
but sleep is foundational.
Yes.
Without sleep, the rest of the day is messed up.
Yes.
So when you have a patient who is having trouble sleeping and you are prescribing progesterone to them, what are your thoughts around that? Like, what do you take into consideration?
Yes.
For that.
So, what I take into consideration is, one, if they're having sleep issues. So it can either be falling asleep. A lot of women will be what we call wired but tired. So they are physically exhausted, but they just can't shut their brain off at night enough to relax and fall asleep. So we have that. And then also, just like the woman who is in your pharmacy, somebody who's getting up at 2 or 3 o'clock in the morning. And so if that sleep component is there, and I'm also a big believer in correcting sleep first, because I do think it's going to spill over into so many other aspects, and sleep is so important for our health, like our brain and our heart, and also for repair and recovery. So if somebody has that, that's usually the first thing I really want to target and make big improvements on, because that's really going to make a huge difference. So if somebody has any type of sleep component issues, I do like to start with that progesterone. And if you're somebody who's in early perimenopause, and this might be one of your first signs, I know I said if you had a uterus and you're taking estrogen, you need progesterone. However, you can take progesterone alone. So if you're somebody who's just starting out and maybe you're not having hot flashes or night sweats, but sleep is the first component, you can take progesterone alone. So it's safe to take progesterone alone. So I would start there. And then dosing also is dependent on the severity of the sleep issues. So, we have a starting dose of 100 milligrams. We can go up to 200 milligrams, sometimes 300 milligrams, depending on the response that we're trying to achieve. So we have the medication, but then we can also increase the dose as needed, depending on how someone is doing.
Okay, that's wonderful. And you heard her say we start at 100, so 100 milligrams of progesterone. And I wanted to also mention here that as the pharmaceutically available progesterone comes as 100 milligrams and 200 milligrams. And the catch with that is that it is made, the company that makes it with peanut oil.
That's true.
Yes. So if you are allergic to peanut oil, you cannot take the pharmaceutically available progesterone capsules.
That's true.
So that is where a compounding pharmacy like Power Pharmacy comes in. And this is why we started compounding at Power Pharmacy, to be able to meet the needs of everybody.
Yes.
So when we have providers send a prescription over and the patient is allergic to peanut oil, we compound their own progesterone. And the other reason why we compound is that sometimes, like you heard her say, she will start the patient on 100, depending on their response. If they're able to sleep on 100 milligrams, perfect.
Right.
What if they need 150 milligrams? What if they need 200 milligrams or 300? We just made a 300 for a lady yesterday. And that's when we compound it without the peanut oil. And this is just a dry capsule. But this is the fun part. The pharmaceutically available progesterone is immediate release. And we are able to compound at the pharmacy sustained release progesterone. Can you tell us the difference between the immediate release and the sustained release progesterone?
Yeah. So,
Yes.
and again, this is where we can try and, tease out the sleep issues. Because
Yes.
sometimes it's more of an issue for women falling asleep. They say, it takes me a hard time to fall asleep. It may take me a couple hours, but once I'm asleep, I do stay asleep through the night.
Yes.
And sometimes it's more of I can fall asleep. Like I'm so tired that as soon as my head hits the pillow, within 5 minutes, I'm out. But no matter what, I'm going to be up at 2 or 3 in the morning. So that immediate release tends to work better for people who need that help falling asleep.
Yes.
And if you're somebody who's like, oh, I can fall asleep, but I need help staying asleep, that's where that sustained release, that we have that effect coming later on at night. And so if you're somebody who falls into one of those two categories, then we can try and,
Figure out.
again,
Yes.
make it more personalized to that person. Now, if you're having problems with both, we may have to play around with it, get
Yes.
creative, and see where we can help. But yeah, that is a great place to be, where we can really fine tune it. And, yes, I like that you mentioned about the peanut oil. I actually have a
Yes.
special question in my intake form.
Yes.
Because, we think about allergies to medication. Sometimes we don't think about food allergies. And I
No.
specifically
Yeah.
have, are you allergic to peanuts or peanut oil? Just so I know that if someone is, that we need it compounded. And then, yes, the commercially available is 100, and then we go to 200. But sometimes 200 is too strong, and 100 is not enough. And having that in-between dose, it's a nice option for women. So I do love that we can make it very individualized if we
Yes.
need to.
I love that. And that's the beauty of compounding. That's the beauty of a personal provider that will take into consideration. Ask about the peanut oil even before. So I love that you do that. That's very kind of you, taking everything into consideration. And that's how you know that that's a provider that has your interest at heart. Another thing that I noticed, when you write a prescription for progesterone and send to the pharmacy, we fill it for the patient, we compound it, get it for the patient. We notice that the patients begin to feel better. Anxiety and mood improves.
Yes. Yes. And so, yes, we know progesterone, again, is working with those GABA receptors.
Yes.
It helps with calm, relaxation. It helps with anxiety. So, in the flip side, that's why sometimes women all of a sudden in the 40s, like, I've never really been an anxious person, and now I'm anxious about everything.
know,
I'm worried
yes.
about everything, and I never used to be somebody like that. So again, kind of highlighting that progesterone deficiency happening first, and how supplementing with progesterone
Yes.
can help with the mood, and it can kind of just take the edge off. So sometimes that's enough for women.
Yes.
Sometimes it's not, and we have to explore other options. But sometimes that is enough to just kind of get them back to, the version of themselves that they used to know.
Thank you. Thank you for being so kind and gentle and like step by step with everybody based on their intake, based on their symptoms, and you take the time. The shortest appointment we do is like 30 minutes, which we don't get that.
Yes.
Which we don't get that with a regular provider.
Yes.
A regular provider in a big health system. The chances that you'll get 30 minutes or an hour, people get to sit down with you for a full hour.
Yes.
So that's a luxury because you get to understand them, you get to hear them,
Yes.
and then you get to use your clinical judgment and all your experience and knowledge to be able to determine what's best for them, incorporating lifestyle and all the things. And I love about you because you look at the whole person.
Yes.
And that's why we work so well together.
Yes.
And it makes me so happy because you take into consideration nutrition. You're always talking about fiber. You're always talking about probiotics, sleep hygiene, what time they're waking up, what they're eating, how they're working out, taking into consideration all the pillars of intentional
Yes.
living. So nutrition, movement, inner alignment, and positive social connections. So I really love and appreciate that about you.
Yes,
Yeah.
because there are some nuanced cases. I see lots of women who are shift workers. So, what does that mean for things like sleep, or when do you take your progesterone? Certainly, I'm not going to have them take it at 11 p.m. at night if
Yeah.
they're working third shift.
Yeah.
And so, yes, it does take time, because I also want to make sure whatever I'm prescribing, whatever I'm saying, it's easy to say, hey, you need to do strength training 3 times a week. Well, how realistic is it? Where can we find these pockets of time? How can what I think will help you, how can you incorporate into your lifestyle? Because we can say all these things, but if I can't make it work for them or show them, hey, this is where I would do it, or hey, we're going to have to take your progesterone in the morning because you sleep during the day, or whatever it may be. And that stuff doesn't come out in a 15-minute visit. You really do kind of have to take the time and let the women tell me their story, what's going on in their day-to-day, what they're experiencing, what are some of the barriers to implementing these changes. And I really like to work with them through that. So more than just prescriptions, but how can we incorporate everything, the nutrition, the sleep, stress management. I like to dive into all of that because it is whole person care.
I love that. I love that. So it's time for supplement school with Emla.
Okay.
And remember, there is no exam. This is just us learning about the supplements that we can use to augment our health. So because we've been talking about progesterone, we've learned today from Dr. Dadhania that progesterone does help with sleep. What are some of the supplements that you see around sleep that we could talk about today?
Yes.
Yeah.
So a lot of times, sometimes when I do supplement women with progesterone, sometimes it's not enough or it's the whole picture.
Yes.
So I spend some time talking about magnesium.
Yes.
I spend time talking about theanine.
Yes.
Those are the two big ones. I'm not usually a fan of melatonin. I don't think it works as well. I think there are side effects. I've had some women tell me it's, they might feel like zombies the next day. So obviously we don't want to be over sedating. Yes. So those are the two that I kind of stick with is the magnesium and the theanine to start.
Yes. And there is also, so I'll expand on that a little bit. You heard her say she's not a big fan of melatonin. Melatonin is really, really used for jet lag. So melatonin is not something that I would recommend for like sleep, because one, high doses of melatonin can cause nightmares and they make people feel a little bit sedated the next day. And we don't want that. We want you to be up and functional the next day. So that's really not what we're trying to do. So that's kind of why I usually stay away from melatonin. If I use melatonin, I would do like 1 milligram of melatonin, or maximum will be at 3 milligrams of melatonin. I will not go above 3 milligrams of melatonin, and that's just me. And so in agreement with what Dr. Dadhania just mentioned. But magnesium is usually my go-to. When anybody comes, when I'm dispensing a progesterone prescription, or anybody talking about insomnia, difficulty falling asleep and staying asleep, my go-to is usually magnesium. Top two magnesiums for that, magnesium glycinate and magnesium threonate. Those ones, magnesium molecules are small enough to cross the blood-brain barrier, helping us to relax and to sleep. And then the magnesium maleate also, skeletal muscle relaxer, so kind of helps, the whole body to relax. And I always remind people that Epsom salt is magnesium sulfite. So when you do an Epsom salt soak, kind of relaxes your muscles, and that way you're able to relax and fall asleep. So top two there, magnesium threonate and magnesium glycinate. Those will be the top two for sleep. And then she also mentioned L-theanine. L-theanine is an extract from tea. So when you hear the British people drinking tea, it's not just for the tea or feel good drinking tea. It actually has a calming effect on you. And that calming effect, it helps you relax. And when your body is relaxed, you're not just sleeping tense, you're also helping relax. So L-theanine actually helps with depression, anxiety, and then helps you have a really good relaxed sleep. So those are some of the top ones that I have for sleep. There are a few others that I use for sleep, but they come in with a lot of drug interactions, so I try to stay away from that. Some sleep supplements, though, I should mention that over-the-counter sleep aids are something that I stay away from. And I try to steer my patients away from over-the-counter sleep aids, because most over-the-counter sleep aids have usually like Unisom, they have doxylamine in them, or Benadryl in them.
Right.
And these are first-generation antihistamines. And when I say first-generation antihistamines, I mean those old antihistamines, which they have different indications that are used in the medical world, but their strongest side effect is causing induced sleepiness, dizziness, drowsiness. So we're taking advantage of this, but there have been a lot of studies that have shown that these first-generation antihistamines, doxylamine, all those Unisom, Benadryl, Tylenol, PM, all those things, they predispose us to early onset dementia. So if you are taking a Tylenol PM consistently for sleep, you need to stop and reassess. Find a physician, reach out, and we have a link to Dr. Dadhania's website in the show notes. Reach out. We can test certain biomarkers that will help to tell you or give us more information. But I am not a fan. Tylenol PM, doxylamine, and Benadryl is not something I would take consistently for sleep. So please stay away from those over-the-counter sleep aids for consistent sleep support. So, and we have not talked and we've not really gone deep into sleep hygiene because we mentioned that with Dr. Roy in the last episode. We'll put a link to that episode and a link to Dr. Dadhania's episode about estrogen in this. I want to ask you that if for an intentional initiative, if you were to give us, some nugget about progesterone or about our sleep and the use of progesterone menopause or perimenopause, what will you leave us with today?
Oh, so let's see. Gosh, there's so much. I know when I walked in here, I told Emma, like, oh my gosh, I think we could talk about progesterone alone for hours as I was preparing for today. But I think, the most important thing I will say is that, as far as, the progesterone goes, that yes, it really is it's, kind of there quietly in the background, but its impact on sleep and our periods is so important. It's usually like I mentioned, the first signs of perimenopause. I think some women think like, oh, I'm not close to menopause because I'm not having hot flashes or night sweats, which tend to be a later sign and symptom. But I think just being attuned to that, realizing that you could just start progesterone alone, you have options, and then also kind of hitting all the lifestyle things. And I think it's a good time to really check in and especially prioritize sleep. I used to be somebody after my second child was born, my workouts were at 5 a.m., 7 a.m. I tried to do it while the kids were sleeping. And now as I'm into my mid 40s, I still do it in the morning, just not quite as early because, now I really value that sleep. And I see, gosh, if I get 8 hours of sleep, I can wake up without my alarm. And I feel so more energized the next day than if I get 5 to 6 hours of sleep. So if I have a choice between getting 5 to 6 hours of sleep and getting a workout in first thing versus sleeping 7 to 8 and trying to figure out my workout later on is what I tend to do. So don't underestimate sleep.
Don't underestimate the power of sleep. If I heard her right, don't underestimate the power of sleep. And progesterone is one of those tools that she uses in her practice to augment our sleep. And so I just share this episode with anybody in your life who could benefit from better sleep. And that is everybody. That is really everybody. And share this episode so that people could learn about the beautiful analogy that she used in describing the role of progesterone and estrogen in perimenopause.
Yes.
I really love that. Thank you very much for coming on. Yes. Thank you very much for listening today. Share this episode, rate it, and continue to live each day with intention.